Hello everybody, here I will be talking about the ventilatory strategies in ARDS, and I just mentioned the year 2017 because of a remarkable paper published in Lancet by Zhao, who looked at the two methods, the low tidal volume strategy, which is a conventional one, versus APRV. If you look at our goals, it is oxygenation and lung protection. In the low tidal volume, we are basically dependent on PEEP. So we have high applications of PEEP, and we believe this recruits the lungs and allows better oxygenation. But in APRV, we look at the mean airway pressures, which is actually the average pressure throughout the breath cycle. Inspiration obviously has higher pressures and expiration has lower pressures. So if most of the time is spent in inspiration, then the mean airway pressures would be higher. And mean airway pressures are the one which actually determine oxygenation. So with a target plateau of 30, we may be able to achieve much higher mean airway pressures in the APRV mode compared to the low tidal volume mode, because APRV is all about inverse ratio ventilation. We have an IE ratio somewhere like 9 to 10 is to 1. So maybe you are spending 5 seconds in inspiration and just 0.5 seconds in expiration. The lung protection in a low tidal volume is basically dependent on the low tidal volume itself. So we have something like 6 ml per kg body weight or even lower for a controlled plateau pressure, and we give a higher respiratory rate to get adequate minute ventilation and wash off the CO2. Whereas in APRV, it is actually about the constant pressures for a longer period of time with a relatively lower respiratory rate, maybe somewhere like 10 to 14. Because the repetitive opening and closing of alveoli, which happens with each breath, is also responsible for lung injury. And it's not just the driving pressure. So if we can bring down the respiratory rate, the number of excursions will decrease, and we hope that it will do less lung injury as compared to higher respiratory rates. In the low tidal volume, we generally have to heavily sedate the patient because of the extreme settings, higher respiratory rates, lower tidal volumes, and paralysis is also considered. It's actually one of the models which has been shown to decrease mortality for the first 48 hours. Whereas in APRV, there is minimal or no need for sedation. So you can actually have a very awake patient on higher pressures being ventilated because the mode allows you to do that. It's all about controlled breaths, at least to begin with, in the low tidal volume arm. So you mostly have these patients heavily sedated, paralyzed, and you take over all the control. Whereas in APRV, it's spontaneous plus assisted breathing from the word go. You can partition between the two. But what you do is you allow the patient to breathe, and this makes him more comfortable and decreases the need for sedation and paralysis. Paralysis is actually of no use, because if you paralyze them, APRV actually becomes the conventional inverse ratio ventilation. The APRV depends on very low expiratory times, as I said, 0.5 seconds to begin with. But is that enough? But that is where we should know a little about the expiratory flow time constant. For any system which is dynamic and increases or decreases exponentially, the time constant is a good way to know how much time would it take to fill up an empty. And in our respiratory system, the time constant is dependent on the presence of airway resistance and the compliance of the lung. So if you have non-compliant lungs, your flow time constant decreases, and if you have resistance, then your flow time constant increases. What we have in ARDS is non-compliant lung, which may actually decrease the expiratory flow time constant. And One time constant means the amount of time which it takes the system to build up or decrease by 63%, and in three time constants it reaches up to 95%. So almost if we get three time constants, then we will be able to empty the lung in that point of time. In ARDS, the time constants may be somewhere like 150 to 200 milliseconds. So maybe in 0.5 to 0.6 seconds, we will be able to empty the lungs by 95%. And so that small expiratory time is just good enough to allow adequate expiration, which actually means it allows you to blow off the carbon dioxide. The inspiratory time constants is also something which has to be looked into when ventilating ARDS. In normal lungs, most alveoli have it as constant, so they fill up and empty at the same rate. But when you have a diseased lung, you may actually have alveoli behaving differently. The ones which are non-compliant will fill up very fast, whereas the ones which have a lot of resistance will fill up slowly. So when we have a long inspiratory cycle, what happens is the slow alveoli also gets time to fill up well. And actually, even if there is no flow, there is flow of air from the fast alveoli to the slow alveoli, which continues. So a longer inspiration improves lung compliance also, because it allows the lung to fill up more uniformly. That is another benefit. So the time constants in ARDS are something which are very favorable for an APRV mode. Here we can just say that if the expiratory flow time constant is increased like it happens in obstructive airway disease, there is no place for APRV. So it just goes out. You only have to have a non-compliant lung for it to work. The long inspiration also leads to lesser derecruitment because the higher pressures stay for a longer period of time and there are smaller breaks in between. The respiratory rate is also low, so the excursions are also less. So believe that oxygenation will improve along with improving compliance, which will actually help you to wean faster. And it will improve oxygenation because the inspiration is long and there is greater involvement of alveoli of all kinds in the gas exchange process. APRV may thus give us the advantage of keeping an awake or maybe mildly sedated patient, allow him for spontaneous breathing, may provide us better lung protection, which would actually mean we will be able to take the patient out of the ventilator faster and he may have less residual damage. And Zhao in 2007, when he included the patients, was able to show that the ventilator free days were more in the APRV mode than in the low tidal volume strategy. So maybe it's time we start trying the APRV mode a little. I will be talking about the settings and the basics of my APRV mode separately. Here I just wanted to arouse some of our interest in this mode of ventilation, which has been there for a long time but which has now gathered attention again because of a new published paper.